This week on Health Garage.
Most of the surgical conditions that you would have otherwise necessitated open surgery can be done laparoscopy. Infertility, where there is tubal blockage, fibroids, endometriosis, adenomyosis, all this can bring infertility. Or heavy menstrual bleeding. We can have ectopic pregnancies, we can have ovarian cysts, and so many. The commonest infections that spoil women's tubes are called chlamydia and Neisseria gonorrhea.
Welcome to the Health Garage. Every woman's dream is to become a mother, but sometimes conditions like ectopic pregnancy, endometriosis, fibroids and blocked tubes can make that dream seem impossible. Tonight, we are shining a light on laparoscopic surgery, a life-changing intervention that's been widely used in many countries, but is still relatively new in Uganda. Joining us is Dr. Sematimba Stephen, a renowned surgeon who will share his expertise. Good evening, and thank you for joining us on our first episode of Health Garage.
I'm Dr. Sematimba Stephen, a gynecologist and laparoscopic surgeon. I'm also a member of Association of Laparoscopic Surgeons of Uganda, and I'm the treasurer of the association. Laparoscopic surgeon, the word laparoscopy is a coin of words, lap and scope. Lap is abdomen, scope is light or a camera. So laparoscopic surgery is a form of surgery which is relatively new in our setting, but has been in existence about 50 years. It involves entry into the patient's abdomen without making large incisions, but rather small incisions to access the abdomen. So we use a camera which projects images on the screen, and then using small instruments, fine instruments, we can be able to operate. We have a screen, as you can see. We haven't started the surgery. We have a screen. We have an insufflator which pumps carbon dioxide into the abdomen so that it can distend, so that it can have working space. We have an image system and a recorder, plus energy sources that we use to achieve hemostasis and dissect tissues. So carbon dioxide has been used since time immemorial for laparoscopy because it's easily diffuses into the body, disappears easily into the body, and as you know, the carbon dioxide is a light gas. So we use it to balloon the abdomen so that we can have working space into the cavity, because if the abdomen is collapsed, you can't have enough working space. The gas isn't dangerous. Laparoscopy is gaining a lot of popularity in the country. People are learning about it. People are now aware about the surgery, and it's not surprising that most women and men will choose to have the surgery instead of having the traditional open surgery where you had to make a very large cut on the skin to enter into the abdomen. So we are receiving so many people. I can't really quantify. I don't want to say I have the numbers off head, but we are receiving very many women, especially that who have infertility, who have fibroids, who have ectopic pregnancies, who opt for this surgery because by and large it's a very safe surgery. So most of the surgical conditions that you would have otherwise necessitated open surgery can be done laparoscopy. So this is just a mode of operation. So some of the conditions in women, for example, will involve infertility, where there is tubal blockage, fibroids, endometriosis, adenomyosis. All this can bring infertility. Or heavy menstrual bleeding. We can have ectopic pregnancies, we can have ovarian cysts, and so many. Well, I may not have enough time to elucidate what exactly to the details, but an ectopic pregnancy is a pregnancy which goes to a tube, which grows in a tube, doesn't grow in the uterus. Endometriosis involves usually women menstruate backwards. the blood flows backwards and then it seeds into the abdominal cavity. Then we have congestion of the pelvic organs, which may lead to pain or infertility. It's just the name that changes. It can be done in any other part, including the brain, including joints, including muscles, including the chest. So it can be done anywhere. It's just the name that changes. Lap means abdomen. So when it goes to the head, the name changes. So well said, the laparoscopy can be done elsewhere in the patient. We make small incisions on the tummy. Incision is a few millimeters. We use what we call a Veress needle. A Veress needle is what we use to introduce carbon dioxide. We lift up the abdomen of the patient to protect the inner organs, and then insert the Veress needle. With the Veress needle inside, we test whether it's in the abdominal cavity. We have what we call irrigation suction test. Then also we do a hanging drop test to see that the Veress needle is in the abdomen. I rightly think we are inside the abdomen, so we introduce the gas through a small tubing, and then I'll tell my assistant to switch on the insufflator as we look at the readings of the insufflator. The insufflator is a very wise machine. It will tell you what's happening inside the patient, showing you the pressures, the flow of carbon dioxide, and if you are not in, you can easily see that I'm not in the patient's abdomen. But clearly, I think, of course, with a lot of experience of working in these patients, I can see that I'm inside the abdomen. And the carbon dioxide now is entering the abdomen, and then the abdomen starts expanding. As you can see, the abdomen starts expanding so that the pelvic and abdominal organs are left down, and then anterior abdominal wall distends. In that, it creates space. We don't have a particular volume per se. The volume depends on how big the patient is, how their girth also depends on how tight their muscles are, and the age. Most cases we use a few liters for the start, and we set pressures. We know the pressure will guide us that once you reach a certain pressure, the machine will stop pumping carbon dioxide. So for us here, we start with 15. We set 15 as a set pressure, and once the machine reaches 15 millimeters of mercury, it will stop flowing. Age is synonymous with size, actually. Size, weight, and girth. It's synonymous. Little children take in less gas than adults. You would expect them to be smaller than adults. So it's just the fact that age is synonymous with size. But laparoscopy can be done on children, adults, elderly, and all age groups. Yes. So as I go on, I try to make sure that we are inside. This Veress needle is inside into the abdominal cavity and not injuring any organ, because it can potentially injure organs. So that's why the people who use this kind of surgery have to undergo through a training. It's not this open. It's not like open surgery where you can learn by seeing. Here you have to do. So that's why we follow a bit of steps here and there so that we ensure patient safety. Also not forgetting that these patients also undergo general anesthesia. She's the anesthetist, and she makes sure that the patient is resting, sleeping, without using any muscles, and she helps the patient to breathe using a machine called our Boyle's machine or anesthesia machine. It helps maintain the patient resting and not moving. Some procedures are shorter than others. Others are longer because of the nature of pathology. So we don't time surgery. But by and large, simple surgeries take about 45 minutes to 1 hour, by and large. So we have reached, you can see, the patient's abdomen is distended. So this is our telescope. This is a telescope which sees into the patient. This one. It has a telescope, camera head, and light source. This is light. So I'll tell my assistant to switch on the light. I'll do some adjustments so that I can get the best image when I'm in. So I'll start. After putting carbon dioxide, I'll go right ahead to introduce my trocar into the patient. So this is called a trocar and cannula. It's what we introduce into the patient so that it gives us room so that we can put other instruments. I'll screw my trocar in, and I think I'm in by that. So when the first trocar is in, it's called the primary trocar. We have put it at the umbilicus. When it's in, we need to see inside the abdomen. Come on, next side. So I'll go in. There I am. So this patient like we said, has an ectopic pregnancy. And an ectopic pregnancy is a pregnancy which goes into the tubes. So this is, you can see she's bleeding inside. She's having internal bleeding. If this patient was left for more 12 hours, she could have been so dramatic, because you can see this is blood inside the abdomen. So these are usually urgent surgeries that we do. So the second report is so small, about 4 to 5 millimeters. It's not so big. It is small, less than a centimeter. So this is the one of the second reports. I'll put another one. Suction. So this is a lot of blood. It's about, I could say about 1.5 liters of blood that we are sucking. It's a lot of blood. And Trendelenburg. We ask for the anesthetist to give us it's called the Trendelenburg position. The Trendelenburg position helps us to push the gut, the intestines, into the abdominal cavity, so that we can have enough working space. These are intestines. You can show them the intestines. These are intestines which we pushed away so that they can fall back this side, so that we can have enough working space. These are intestines, as you can see. When you push the patient on the Trendelenburg position, the intestines run away, and then they give you get enough room for working. All these are clots that we are sucking. They are a lot. This patient had overbled, and she was not dynamic and very stable. This is the tube which has ballooned. This is the tube which was harboring the ectopic. When you look at this side, this tube looks normal. Show them. This is the normal tube. This one. It's normal, but now this one is ballooned, having the ectopic pregnancy, and it was bleeding. So you call this one a leaking ectopic pregnancy. So this patient is going to lose her tube, and she'll remain with one tube because this tube is beyond repair. It's too ballooned. When you leave it, you'll have left an organ which won't help the patient. So it can even lead to another ectopic pregnancy. So I'm trying to irrigate so that I get a better image. Wash the patient with sterile water. Stop. So that I can get a clearer image. When there's a lot of blood, the image is blood. Not as good as when you suck out the blood. You can see the image is now better. So this is the uterus. This is the uterus. Woman's uterus appears like that. This is the tube. This is the fallopian tube. What you see as white down is the ovary. That is the ovary. What you see as white. Yes. So the tube is close to the ovary. The egg is picked from here to the tube, and then fertilization takes place in the tube. Then the embryo is taken to the uterus. is carried from here. Egg is picked by the tube. Then fertilization takes place in the tube. Embryo is formed in the tube. And the normal is that the embryo is supposed to be transferred, moves to the uterus. This is the uterus. But sometimes it doesn't happen that way. The embryo remains in the tube. And that's how people get ectopic pregnancies. And the commonest cause of ectopic pregnancies is women who have infections, who get infections. Sometimes they're not well treated or not treated. And then the tubes get spoiled. So the movement of the embryo in the tube is not proper because the tube is spoiled. The commonest infections that spoil women's tubes are called chlamydia and Neisseria gonorrhoeae. I'm using energy to remove this tube. Yes, I'm using energy to remove this tube. So I'm coagulating and cutting at the same time, as you can see. So this is what we usually do if you are not going to save the tube. So this tube, we are not going to save it because it's not one type you can easily save to help the patient. We have detached the tube from the ectopic from, this is the ectopic. It's quite big, so usually go back where we have worked and make sure it's not bleeding. The patient remains with an ovary, but without a tube. But the beauty about science is, even where we have cut the tube, this tube, that is this side, if by chance you ovulate from this side, this tube can pick an egg from this side. You see, it can reach. This tube can reach very well. It can reach. It can pick very well and can pick an egg from this side. However, it's meant to pick from here, but you know nature is about adjusting. So now we plan the final part of the operation, which is retrieval, retrieving the ectopic. So this is how the women's internal organs look like, the pelvic organs. This is how they look like. Again, I repeat for you, this is the uterus. This is the tube of one side which remains. There you go, this is the ovary. Please, camera, come closer. That is the ovary, as you can see. That's the ovary. This is the ovary of this side. These are the vessels going to the legs. These vessels are the blood vessels going to the legs. This is called the round ligament, that one which hangs the uterus, supports the uterus, and so on and so forth. This is the bladder here. The bladder is here. Yes. So, and this is the rectum, which keeps stool. This is the rectum, which goes into. See, they are near. They are near each other. The rectum and the uterus. This is the rectum. Maybe what is limiting is now the equipment. But we are now quite a number. I would say maybe about 50. Yeah. So we have different surgeries. This is supposed to be a basic life-saving surgery, which every surgeon should be able to do. These are life-saving surgeries like ectopic pregnancies, cesarean sections. We expect most of our trainees, surgeons, to be able to perform. So we insert a small bag. This is a glove. This is a small bag you can show on the screen. Insert a small bag for retrieval. And this is where we put what we are supposed to retrieve. We pass through our primary pot, and then it goes into the cavity. This can take another 35 minutes. That's what makes this surgery a bit longer. Actually, what we are doing is what makes this surgery a bit longer. Are you sure, sir? Yeah. Mugongo. trophoblastic tissue. Yes, you got them. So we are done retrieving the tissues. So the next thing is we are going to clean with water, sterile water, then you close, finished. Well, the cost of laparoscopy is still a bit more expensive than conventional surgery, definitely, because it's more sophisticated. It gives you benefits of less hospital time, less time in the hospital, less risks of infections, more cosmesis. So and so many other benefits. So it's still a bit costly. In our setting,
if you are overweight or underweight, you are unable to go through this procedure. How true is that?
Well, the myths are there, but surgery is all the same. The difference is this one is minimal access. Surgery is the same. The difference is this is minimal access. We access the abdomen through very tiny incisions. So, of course, the obese people have a disadvantage a bit because they are more likely to have infections in any surgery. They are more less likely to get clots in any surgery. So it's a bit tricky for obese people. But by and large, your doctor should ensure that you are safe for any surgical procedure. One of your goals is demystify the myths that the population has about surgery and per se laparoscopic surgery because it's still new. But I need to tell you, laparoscopic surgery is much safer than what people think, because this scope magnifies the abdomen. You can see how you're able to see. If I was doing open surgery, I wouldn't have seen anything. And all of us are eyes. My assistants are eyes. My anesthetist is an eye. They will tell you, no, doctor, why don't you look at this? So it's an interaction of everyone. That's what makes it much safer, because you don't work alone, unlike open surgery. Everyone has a view, an idea of what you are doing, and they can advise. I need to tell you, laparoscopy is one of the safest procedures. Today evening, this patient will be going home. She will be going home. Because the patients don't take long in hospital, you don't need a lot of space for the hospital. You need like 3 beds to work on a very big number of clients, because you don't have patients don't have to wait in hospital for a long time.
So, doctor, we are continuing to demystify these myths and misconceptions that people have. And another one is that after this surgery, you get less egg count. How true is that?
It's not true, because most cases we use our energy sources away from the ovaries. Unless the surgeon, for some reason, which can happen anywhere, even open surgery, applies energy on the ovary. Because eggs are from the ovary. So if for some reason the surgeon applies energy on the ovary, which can also occur in open surgery, you can have less egg count. But by and large, we avoid applying energy on the ovary so that a woman remains with their fertility. When you have a previous operation, your surgeon should be let know of what exactly happened, so they take all precautions so that you are safe. These myths and misconceptions apply for both open surgery and laparoscopy. Because as a surgeon, I'll be more cautious. If I'll be more cautious to save your life, or to make sure I don't injure anywhere, just in case the previous surgery was a complex surgery. Some surgeries can be longer than if we are done open. But the beauty about laparoscopy, it's more meticulous. There's more fine dissection, more fine handling of tissues. So it's longer but more meticulous. You'll have a much cleaner surgery if you did laparoscopy. However, for the issue of anesthesia, the surgeons and anesthetists have put all measures through experience and of years of experience. They have put measures to make sure the patient's life is safe. what we will always put patient safety first. So all these things we do, the first thing is patient safety. Everything. Sometimes we even abort surgeries if we think the patient's life is at risk. So at all costs, we make sure the patient life. So the patient, people shouldn't fear anesthesia because we give priority to life first. Yes. This one is an umbilicus. It will even disappear. It will blend very well. It can't even be seen. And this one is about 0.4 millimeters. You can imagine how small it is. These two, they are very small.
Doctor, how long does it take for these incisions to heal?
She can go back, she will rest today,
Okay.
tomorrow, and on Monday she'll be, after 3 days she'll be back to work.
So can she also do normal activities like lifting weights, heavy things?
I would think so, depending on how much stress how much pain you have.
Okay.
But in most cases, because it's not so painful, I would expect them to do their routine.
Okay.
Thank you very much for coming over. You really wanted to see what happens in laparoscopy. We just had a successful laparoscopic salpingectomy. That means we have removed the tube, which was bleeding due to an ectopic pregnancy. So it really feels rewarding for us to have minimal access surgery for such simple operations. And I know the patient will benefit from this. We have been able to look at other organs, including her liver, her intestines, her uterus, and they all looked normal. What we have at hand, laparoscopy is now the best procedure that would benefit our patients that need surgery because, like we said, it gives so many benefits. And not so many centers are doing it, but for us here at Crystal Medical Center, we are no longer doing open surgeries because we think the world has to move and we need to move on. So we are doing laparoscopic surgery for most of our surgeries, including ectopic pregnancies like we just did, fibroids, when someone has infertility due to tubes, ovarian cysts, and so many others, including very complex surgeries like endometriosis surgery. Usually there are telltale signs when there is disease. Usually the first thing could be pain. When you are pregnant and you get unexplained pain, you start to think what's happening. You need to go to the nearest facility, nearest doctor to check you. When you have a bleeding, because an ectopic pregnancy, for example, can present like a miscarriage. Okay, so there are so many things women can look out for, but when you have something that you consider abnormal to your body, like bleeding, pain, please be able to see the nearest doctor to help you. There are so many other diseases which can be treated, and for example, infertility. I have passion in treating, helping women who are infertile, and we have had so many success stories using this very method to treat infertility caused by fibroids, tubal blockage, or infections, because usually most women have tubal blockage because of infections, and so many others. So we are located in Rubaga, Kabusu, near Tal Cottages. Yes. My number is always on. I'm always all ears. Please reach me on 0704 78 93 80.
Thanks to Dr. Sematimba Stephen for shedding light on laparoscopic surgery. If you are struggling with any of the conditions mentioned, don't hesitate to seek medical attention at your nearest hospital.
The Health Garage, transforming lives one healthy choice at a time.